So welcome to the session, guys, about the questions asked in the June 2026 FMG examination. So I'll wait for just a couple of seconds before we start. Yes, okay, fine. So uh, approximately 18 to 19 questions have been asked. Were the recall whatever we could get from our students, and the disclaimer is number one. This is just a recall given by the students who came out of the examination hall. So there is a possibility of changing the statement and and choices also. In some places we could not recall the choices. We'll be very, very transparent with you. It's a very raw recall at this moment, and whatever we will be able to polish it up, we'll be putting in the app in the subsequent number of days, like coming days only. Okay. So uh, the the first question which was very, very, I put a snippet of the like notes also where the question came. So 20-year-old male itching in the ear, and they have given the very beautiful picture of the fungal debris over there, the wet newspaper appearance, the blackish spore, whitish hyphae, and we have done it in the class also. It is otomycosis, and this appearance is called wet newspaper appearance. It is there in your ear notes over there. So very straightforward question was otomycosis because they had written wet newspaper appearance. Again, I say this is recall by the students only. So maybe, but even if they give you a picture like that, and I think you remember the class discussion over there, otomycosis wet newspaper appearance. It's very, very easy question. I hope you're able to score this. Approximately 18 to 20 questions were there around in ENT. Whatever I could recall, I'm telling you one by one. Again, a very, very expected question. It was thyroid surgery and nerve injuries. And this was there in the MIQ session of ours also, most important question session also. Thyroid surgery, done for the colloid nodule. But after that, patient is unable to sing properly, high pitch voice is not able to achieve during singing. I think you remember this discussion in our notes also, in that if at the upper pole SLN is injured, a branch of SLN is called ELN, external laryngeal nerve, and ELN supply cricothyroid muscle. And cricothyroid is the main tensor of vocal cord, and tensor gives us quality of voice. So poor quality of voice is the problem in singing the song. And examination shows bowed down vocal cords. So very beautiful question. Please comment in the chat box. Could you attempt these two questions correctly? I want to know, if you have attended the classes, on online live or the offline or the recorded lectures. Could you attempt the question external laryngeal nerve or external branch of laryngeal nerve? Your comments are very, very important because they will tell me that is the recall, close to the real exam or not. Question number one, tell me otomycosis, could you score well? And question number two, could you relate to the class discussion? If after thyroid surgery, patient is unable to sing the song properly, the the answer is ELN or SLN injury. And if patient is unable to breathe properly, it is bilateral RLN injury question. Okay. Please comment in the chat box over there. Now, next question again, like 7-year-old child with high-grade fever, drooling of saliva or dinophagia. X-ray picture was given over there, and you see very beautiful widening of prevertebral shadow over there. And this was there in our notes. If you remember, the same picture was there in the notes also. And the diagnosis is acute retropharyngeal abscess because retropharyngeal space is behind the posterior pharyngeal wall. If pus collection is there, then there is a possibility of acute retropharyngeal abscess because this area has got retropharyngeal lymph nodes, and suppurative inflammation of retropharyngeal lymph node will lead to acute retropharyngeal abscess, and it's an airway emergency in children. And you can see the same drooling of saliva word there. All those things are generally, this is snippet from your notes only if you remember. Okay, fine. And the answer of this question will be of course, the acute retropharyngeal abscess. Why it's not Ludwig angina? Of course, chin swelling is not there. Why parapharyngeal abscess is not there? Because lateral neck swelling is not there. And quinsy will be having internal oral picture of uvula pushed to other side, trismus over there. So I hope you all could score this question correctly. It is not Ludwig angina, no chin swelling there. It is not parapharyngeal abscess, no lateral neck swelling there. No peritonsil abscess of quinsy. Why? Uvula is not shifted and trismus is not there. Tonsil is not pushed medially. It's a abscess in front of vertebra. And same picture was there in the node. Widening of prevertebral shadow is the acute retropharyngeal abscess. Okay. Please comment in the chat box. Did you score it well or not? Now again, Adenoidectomy done for adenoid hypertrophy. After surgery, child develop hypernasal voice. Hypernasal voice. Remember page number 23 of your larynx notes, rhinolalia aperta. Page number 23, rhinolalia aperta, hypernasality. It is due to cleft palate actually. If you remember hypernasality is due to cleft palate. Any palatal problem lead to hypernasality, or what could have been, unmasked by adenoid hypertrophy. Patient getting hypernasal voice. Please see hypernasal voices, rhinolalia aperta is page number 23 of your larynx notes. And what could have been the reason behind it? It is the cleft palate issue which has been unmasked after surgery. Patient was having the hidden cleft palate below the mucosa that has been unmasked after surgery. So that is what, if you remember this rhinolalia aperta hypernasality, any hypernasality of the patient voice will be due to palatal problems, you will know the answer. And I'm really curious to know, did you attempt this question correctly or not? Because this is what we keep telling the class, that you have to focus on because class, the question will be clinical scenario based question, and they come based on your notes, and you have to interpret the question as per the knowledge you have taken from notes. And that's why your comments are very, very important for me to understand that what went exactly in the paper, that what you were thinking. Could you relate to rhinolalia aperta of larynx notes, and you could relate to cleft palate story or not? Okay, fine. Okay, if acute epiglottitis was there in this question, then epiglottitis is not an answer. Why? Because epiglottitis will not have X-ray finding like that. In epiglottitis, the X-ray finding is thumb sign. I'm glad they said that there was a differential diagnosis of this question was acute epiglottitis. Very beautiful differential diagnosis. But I know in differential diagnosis of epiglottitis, we'll be having thumb sign, and it is not thumb sign, it is widening of prevertebral shadow. Okay, fine. Now, next question again, very, very scoreable question. Diabetic man with the uncontrolled diabetic status, high glucose level, blackish crust in the nose. I think we know the answer. It's mucormycosis. Because I hope this question was, correct for everyone. The appropriate management, again, it is not really the antifungals only. It is surgical debridement with amphotericin B. I hope, please comment, was this the correct choice for you? Surgical debridement with amphotericin B. It can't be surgical debridement only. Why? Please see, we have written a drug of choice over here, but we said debridement is done first. Hai na? It's amphotericin B. Okay, fine. Now, very good. Now, next one, fine. Next one. This one is the answer is A, fine. Okay, fine. Now, I am reading your choice, if the question of this one had the other choice like croup also will be having the steeple sign. Steeple sign is widen the narrowing of the subglottic area. Okay, fine. Now, so this, okay. Now this again, your common sense question. Do you have heard the word of flexible endoscopy? If you remember the first page of your notes of the larynx, FOL, fiber optic laryngoscopy, where you will keep the tip of the endoscope if you want to see the mobility of the vocal cord, because you want to see the movement of vocal cord. Where would you see? You can't see at piriform sinus. What is piriform sinus? Piriform sinus is part of pharynx actually. If you remember, this is piriform sinus right and left. It is not part of larynx. Larynx is here. So you can't go to piriform sinus over there. That's choice ruled out. Okay. Now, you can't be between the arytenoid also. Why? Arytenoid is the posterior one third of vocal cord. If you're between the arytenoid, actually, how can you check the movement of vocal cord? You'll not let it move. There'll be a lot of gag over there. And you can't be at the base of tongue area also, because base of tongue is too high. So you have to go a little bit below the tip of the epiglottis. The answer was below the tip of epiglottis. Tell me, could you answer this question with the anatomical knowledge you have? It rule out. It can't be piriform sinus. It can't be the arytenoid area. It has to be somewhere between the B and D. And could you answer this? You have to go a little bit below the tip of the epiglottis. Below the tip of the epiglottis. Okay. Okay. Now, this one again, mastoiditis question was straight away from the notes again. Mastoid edema there are running out of the mastoid surface. Actually, acute mastoiditis topic. And patient has got fever, pain, swelling over mastoid region. And there is the display of but no headache there. If no headache there, if you remember this page of your notes, we said that in sigmoid sinus thrombosis called lateral sinus thrombosis, headache is also there. Headache is an indication of intracranial infection as a complication of ear infection. So in mastoiditis, we have got the ironing sign, which is very much clearly visible. It can't be abscess. Why? Bizold abscess is along the sternocleidomastoid, which is the middle part of the neck on the lateral aspect. It's behind the pinna swelling. Was this picture there? Tell me. Was the picture there behind the swelling behind the pinna? So the answer, if that was the case, then the answer is very beautiful, mastoiditis. Why? Because Bizold abscess, Ridley abscess are neck swellings. Bizold is along sternocleidomastoid and Sitlis is along the digastric posterior belly. Okay, tell me, was the picture there? Tell me, was this picture of edema behind the pinna there over there? I need your comments over there so that we are able to understand that we are close to what exam really asked actually. Okay, fine. Okay, fine. Yes, of course, vallicula cannot be the answer of this question. Why? Somebody said that Dr. Dhawan, vallicula was there, one of the choices. Yeah, base of tongue and vallicula are more or less same area. If you remember, vallicula is a part of oropharynx. You remember vallicula? Vallicula is the space between base of tongue and epiglottis. Vallicula is the space between, if you are in the vallicula, you can't see anything. Vallicula is the space between base of tongue and epiglottis. So you have to go a little bit below the tip of the epiglottis and you see the vocal cord. Very good. Okay, fine. Now, this was a little bit radiology and the NEET PG style question over there. Peanut butter appearance in a sinusitis case. And if you would have done the radiology classes, this kind of, picture, if you remember, the normal polyp are homogeneous, heterogeneous, double density shadows radiology. This is the CT scan of the paranasal sinuses showing heterogeneous or double density shadows. In a case of sinusitis, this is indicative of fungal sinusitis actually. It is not mucormycosis, fungal sinusitis. This is a radiology, typical double density shadow on the CT scan or the you can say the heterogeneous shadows of the sinuses in a case of fungal sinusitis with the peanut butter appearance. This is AFRS, allergic fungal rhinosinusitis over there. Now, again, this question came about the lateral wall of nose. They had given a picture. Tell me, was the picture like this or cadaveric picture? Was the picture like animation picture or cadaveric picture? Because in the class, this is class notes. You've done both the things over there. This is cadaveric picture. And I think they had put the arrow in the superior meatus area. And if the superior meatus is there, then the answer is posterior ethmoid air cell drain into the superior meatus. Because sphenoid, this S is sphenoid. Sphenoid drain into the sphenoethmoidal recess and nasolacrimal duct drain into the inferior meatus and maxillary frontal antiethmoid drain into the middle meatus. Okay, so was the arrow in the superior meatus zone? Was the picture animated picture or cadaveric picture? Okay, if the arrow was in the superior meatus over there, the answer is posterior ethmoid air cell. Okay, animation was there. Could you attempt this question correctly? Was the arrow in the superior meatus? Please tell me, was the arrow in the superior meatus? If the arrow was in the superior meatus, then the answer is posterior ethmoid air cell. If the arrow was in the sphenoethmoidal recess area, then the answer will be sphenoid sinus. Okay, please tell me if you remember where was the arrow. Very good, very good. That's a correct answer over there. Okay, now again, you know, the class study is very, very important. We have discussed the topic of, normal tympanic membrane, retracted tympanic membrane, retraction pocket, cholestoma. If you don't treat retraction pocket, they lead to cholestoma formation. If you remember this page of your notes, if you remember the story, normal TM, retracted TM, retraction pocket, cholestoma. If you don't treat retraction pocket, there will be cholestoma. Cholestoma is skin in the middle ear. Fine. Now everybody please see the patient has got there is no history of hearing loss, but there is a retraction of tympanic membrane, retraction pocket, in fact, not retraction pocket. So whenever we have got the retraction pocket, and if you remember your notes, the next page was, if you written over there, and few years later, if retraction pocket is not managed properly, it will be leading to formation of the cholestoma formation. And what will be the treatment? Now please see, can we observe it? Not at all. Why? Because if you keep observing it, it will become cholestoma in the future. Can tympanoplasty be done? No. No. Why? Tympanoplasty, maryngoplasty are for the perforation of the past tense. If you remember, safe CSOM. Okay. Now, the only thing left is the grommet. Grommet. Grommet is ventilation tube insertion. Why? Retraction pocket is due to ET dysfunction. And what is the role of grommet? Grommet is middle ear ventilation tube. What is the reason behind retraction pocket is the eustachian dysfunction, which lead to middle ear ventilation issue. And what is the other name of grommet? Grommet is the middle ear ventilation tube. So This was the answer. How to solve this is again, they want you to think about not just the theoretical thing. Retraction pocket will lead to colostoma formation is there in your notes. Okay. Grommet is also called middle ear ventilation tube. We have put the surgical video also over there. And you know, middle ear ventilation is done through the grommet. So in this case, the answer will be grommet insertion. Okay. Now, next one. Next one. This one. Again, same thing which we've discussed in the class also. Juvenile papilloma of larynx. The same picture almost was there. There were multiple papilloma on the vocal cord of a child, and they said that it's a 2-year-old child, juvenile. Okay. Lesions. Then they say the excise. I don't know whether they gave the cidofovir also or not. Okay, fine. Next, everybody. The which HPV strains are most commonly? I think HPV 16 and 18. Okay, could you attempt this question carefully? 16 and 18. How many questions came this time approximately in ENT? Approximately 18 questions were there. 18 could be recalled as of now. There was some anatomy doubtful, but 18 question I could get. I'll show you if you some question did not come, let me know. Was this question there? Was the question there? Could you attempt this question correctly? Okay, fine, fine. Now, see, this was the topic of juvenile papillomalarynx is caused by HPV 16 and 18. And we had seen the surgical video also that carbon dioxide laser is used to, remove these papilloma. And in fact, we had written this time that in the classes that after surgery is over, intralesional cidofovir is injected into the vocal cord after surgery. I think if you have the latest class notes, you'll be seeing that we have done that. The HPV 1618 was a very quick answer over there. Okay, fine. Now, next one. Again, there was a video-based question. And if you remember the class videos, we have seen the video vocal cord palsy. At least you could remember. At least you could remember the vocal cord palsy video has been shown in the class only. If you remember carefully, that one side movement was not occurring. Now, understand this question. I'm not sure about this question. What was the position or what was the timing of the history of the patient? They say there is history of a 2 months actually. 2 months, okay? And the video was there, and one of the movement had vocal cord movement issue, and vocal cord was lying in the abducted position as per the recall. Maybe wrong, maybe right, I'm not sure. But if you remember our notes, unilateral vocal cord palsy, single side cord palsy, the treatment is conservative. We had done one MCQ also that 62-year-old patient present with unilateral cord palsy. What is the treatment? Conservative. If conservative was not in the choice or the history was not given properly, then if the vocal cord was in the open position, then type 2 thyroplasty is the answer. If you remember, go to lab. Go to lab. Remember type 2 thyroplasty? Type 2 thyroplasty is done for abductor paralysis of vocal cord when vocal cord is not coming towards midline. If vocal cord was not coming to midline, there's a gap over there, then you need to do type 2 thyroplasty, which is lateralization of which is the, if vocal cord was in the abducted position, like that, the open position over there. Let me remind you, no confusion over here. If the question was mentioning no conservative treatment as a choice, then rule out conservative, that gone. Otherwise, unilateral cord palsy on the video, if shown, and conservative was there, then conservative was the answer. I'm not sure about the recall over there. Now, if the cord was in open position, open position is adductor paralysis of vocal cord, adduction palsy. For this, we do type 1 thyroplasty is medialization done for adductor palsy. Okay. If cord was in closed position, not moving laterally, it is abductor paralysis of vocal cord. Then we do type 2 thyroplasty, go to lab. Lateralization for abductor palsy. Okay. Fine. Everybody. Fine. Great. Option में अगर 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 कंजर्वेटिव था ही नहीं, let us really delete it. Let us really delete it. अगर conservative नहीं था, then you remind yourself which movement was not occurring. Look at my hand, beta. Look at my hand. If cord was not coming towards the midline, other cord coming towards midline, but this was not going to midline. There was a gap there. There's a gap there. then you have to think about the abductor paralysis, and then you have to think about the lateralization. So depend. I'm not sure about the video because video was there. So basic rule is that if cord is in towards the already midline position, it's not opening up, then you do the lateralization of the vocal cord type 2. If cord was already in the open up position and cord was in the adductor paralysis position, then you do type 1 thoroplasty or medialization of vocal cord. Okay, fine. Now, next one. Now again, please see. Beautiful question. Cancer larynx, we had said that it is there in MIQ. Also, 3 questions were there on the cancer larynx only. Staging question was there. And I think you remember we had done the staging. T1, one structure involved. T2, more than one structure involved. T3, vocal cord fixed or immobile. And T4 is invasion of thyroid cartilage. And then the treatment protocol also. In this question, as per the recall, they're saying that there was the fixation of the vocal cord. Right true cord is fixed and the imaging demonstrated invasion of thyroid cartilage. T4 is there. And we said that for T4, the laryngectomy with radiotherapy is the answer over there. So answer will be total laryngectomy plus radiotherapy. What was the choice in this question? What were the choices in this question, Mita? Okay. Okay. Everybody tell me what were the choices in this question? Was it T4? Invasion of thyroid cartilage was there? Invasion of thyroid cartilage was there. Tell me. Invasion of thyroid cartilage was there. Yes or no? Okay. Yes or no? Invasion of thyroid cartilage was there. If invasion of thyroid cartilage was there, it is T4. For T4, we go for what? The total laryngectomy. Total laryngectomy plus radiotherapy. For T4, we go for total laryngectomy plus radiotherapy. But if vocal cord is fixed given only, T3, remember T3, we go for concurrent chemoradiation. I hope you remember this snippet of the class over there. For T3, vocal cord is fixed or immobile. Okay. If thyroid invasion was not there, it is T3. And for T3, the standard treatment nowadays is what? Concurrent chemoradiation. And for T4, if the thyroid invasion is mentioned, okay, then there will be the T4 will be total laryngectomy followed by radiotherapy. It depends on which choices were there over there. Redkowski staging was for angiofibroma. It is there in our notes also, bache. If you remember angiofibroma, we had remember 2 staging name over there, fish staging and Redkowski. Was staging of angiofibroma asked actually? Tell me, was staging of angiofibroma asked? Whenever invasion of thyroid cartilage is there, it is T4 and for T4 we do total laryngectomy and radiotherapy. अच्छा 2 क्वेश्चन आए थे. Then that's why people are having 2 different questions over there. If vocal cord is fixed, it is T3. If thyroid cord is invaded, it's T4. Were 2 questions there on cancer larynx? Were everybody please comment? Were 2 questions there on cancer larynx? Okay. If invasion was there, it is T4. Answer is total laryngectomy, surgery with radiotherapy. Very good. Now, this question, beautiful question. The after parotid gland surgery, anesthesia of the lower part of the pinna is greater auricular nerve injury. I hope you remember this thing we discussed for there. Fine. Everybody, please see. Patient has got what? The same notes over there. Greater auricular nerve, nurse flare pinna. We've done it also the lobule of pinna, and we written there. I think you remember that in the class parotid gland is there. Any surgery, we had done one MCQ also over there. After parotid surgery, anesthesia of the lobule or the lower part of pinna is due to greater auricular nerve injury. Okay, fine. Next one. Next one question was about airway, foreign body, cancer, larynx are favorite topics. You know it, na? Now please see airway, foreign body. This question, do you remember? What was the statement? Restaurant scenario, patient developed choking, unable to cough. Is laryngeal foreign body question? Heimlich maneuver. Tell me, Heimlich maneuver. Do you remember Heimlich maneuver? Heimlich maneuver. You remember this question came. The foreign body airway larynx question, restaurant scenario, patient unable to breathe, choke, unable to cough. This all is laryngeal foreign body situation. What is the basic treatment for this patient is Heimlich. Okay, fine. Heimlich. Okay, fine. Now, one question came about was a tracheostomy. Was this question there? Best tracheostomy tube for ICU patient or maxillofacial trauma patient was the, Portex PVC cuff tracheostomy tube. And we discussed in the class notes also, remember, Portex PVC in cuff decrease aspiration. Okay. Railway station, very good. Very good. Hemorrhage is the answer. Very nice question. Railway station pe tha. Very good. Arch wala question bhi aaya tha, yes. Was this question there? So many questions then. It's already like we have touched 18, 19 question. Huh? Fine. And you're saying cancel area had two question over there. Please confirm cancel area had two question or one question. One question came on the ear embryology. Remember ear embryology question, something about the pinna defect was given, pinna defect and some stapes defect. Were the two defect given over there? Stapes and pinna defect both were given. And I think you remember the snippet of your notes over there. Pinna developed from two arches. Tragus from first arch, rest of no second arch. Okay. And what was the answer? Stape, if you remember your notes, malleus inca developed from first arch, stapes from second arch. Second arch, very good. Okay, so if stapes was having problem, it's a second arch defect. Second arch defect. I guys, can you tell me? You know, can you tell me this question was there that the development of the ear question embryology pinna defect was mentioned over there, and they had mentioned about something about stapes also. What were the choices? First arch, second arch, third arch, fourth arch. If stapes was also having a problem, okay, then stapes has a problem over there. What were the choices? One, first and second arch, second and third arch, like that, or what were the choices like that? And I think is stapes is also defective. I'm not sure about stapes was mentioned or not there. If stapes is mentioned, he wants to have an answer of second arch because stapes develops from second arch over there. Okay. So if you see roughly, if pinna, if we see the second and one, okay, fine. So pinna develops second and first arch. So basically they were arcing the, okay, लिखा था. अगर second और first arch लिखा हुआ था, तो pinna defect is from first and second arch. If stapes also mentioned and first and second arch was not in the choice, if stapes only was asked, second is the arch. Why? Stapes from second arch over there. So these were the question. Let me show you one more time. What were the question asked? Number one was otomycosis, straightforward wet newspaper appearance. Singing problem after thyroid surgery is the external laryngeal nerve injury. Straightforward question. Retropharyngeal abscess. That picture from the class notes only. The retropharyngeal abscess question over there. Then the rhinolia aperta hypernasality cleft palate issue was asked over there. Again, your class snippet over there. Then mucormycosis, straightforward question. Debridement with amphotericin B is the correct answer. And where you keep the tip of the laryngoscope will be just below the tip of the epiglottis. Okay. Mastoiditis, visual question was there behind it. Edema of the mastoid. Again, straightforward. Again, same picture in your notes over there. And I hope you remember this question. Yeah. I think one more question came on nasopharyngeal carcinoma. Yes. I was very happy seeing this question. Did you smile when this question came? 55-year-old man, with recurrent episodes of unilateral blockage and unilateral hearing loss. I hope remember a child getting hearing loss is a glue ear question, but a 40 to 70-year adult getting unilateral glue ear is nasopharyngeal carcinoma question. Okay. Guys, did you score this question? This was the, again, I think this is part of your notes only. With multiple number of time we said this in the class that a child getting glue ear, think of adenoid. But 40 to 70-year adult getting unilateral glue ear, think of nasopharyngeal carcinoma. Anyway, look at the age, 55. I want to hear your comments on this. Did you attempt this question correctly? Unilateral hearing loss is there. Okay, so why cervical lymphadenopathy is there? I hope you remember NPC, the most common clinical presentation is metastatic cervical lymphadenopathy. The answer to this question is nasopharyngeal carcinoma. Do you remember this thing we said that? Okay, fine. Fine. So then this NPC came, then this fungus sinusitis, then lateral wall anatomy, cadaveric, this picture of the drainage of posterior ethmoid air cells, and then retraction pocket glomerulus insertion, then HPV 1618 over there, then quad palsy video, then cancer larynx 2 question over there, parotid surgery, the anesthesia lobular pinna, greater auricular nerve injury, choking while eating is laryngeal foreign body hemorrhage maneuver. Okay, fine. And then best tracheostomy tube. Was this question there? I want to ask everybody. Was this question there? A patient of maxillofacial trauma. Which tracheostomy tube would you prefer? Which tracheostomy tube would you prefer? Was this question there? Please tell me yes or no. Okay. So if this question was there again, like they're testing your, knowledge from a clinical angle, and I hope you could score this question correctly. Fine. Hmm. Hamlet maneuver, we have discussed in the class also. In Hamlet maneuver, what we do is we put the pressure backward and upward. If you remember, in Hamlet maneuver, we said that in Hamlet, we said the pressure is given in the backward and upward direction. It's written in the notes also, backward and upward. Epigastrium pressure in backward, upward direction. Okay. And if you want to keep the patient on ventilator for the maxillofacial trauma, which tube would you prefer? Of course, cuff tube. Portex PVC. Was this choice there? Portex PVC, cuff tube was the choice there. Cuff tube. Okay, very good. Then you score it correctly, beta. Because for tracheostomy, you need to have cough decrease aspiration. Yes or no? Yes or no? And lastly, the two cancellary question and the ear embryology question. And I think they had given, like very again, the thing is, if you have got the conceptual clarity, think about mucormycosis, you have done singing problem after thyroid surgery, it's correct question again. Lateral wall anatomy, mid posterior mod air cells, correct. Laryngeal foreign body, Hamlet maneuver, correct question over there. Similarly, Portex PVC cuff tracheostomy tube, cancellaries management question over there. So they have not debated too much actually, but yes, there are sometimes the way of the video question and all those kind of discussion are there. But then look at this one. They want you to score. Then people are having very clear cut now that nasopharyngeal carcinoma is there. Fine. Unilateral glue ear hearing loss in a 40 to 70 year adult will be NPC story. So that was there. So these were the approximately, I can say 18 to 20 question came out of ENT as of now. However, the correct recall, exact recall, we'll try to create after few days when we get the better recall with the better choices. If you have any comments, anything about choices and all that, how your paper went about, did you score well in ENT or not? I'll be very happy to know that, what was your feeling in the paper, because paper made you think like clinician. I'm aware people are having very genuine opinion about the paper was of very high level clinical paper where they had created the clinical situations over there like this one. But if you remember, this was discussed in the class multiple number of time in the main classes, in the MIQ sessions, also in the TND format also. Okay, fine. Okay, fine, guys. Thank you very much. And this is the end of the session. And please come to the app after a couple of days for the proper recall, also with more verified choices over. I wish you good luck and do not really create undue anxiety about the results. Just stay, like prayerful and stay hopeful, because 150 out of 300 without negative marking is achievable task actually. I know currently your brain is reminding you of many questions which you find tricky or difficult to answer, but there were a lot of questions which you have answered correctly. Like look at this question on, could you not answer mucormycosis correctly? Hamlish maneuver question, could you not? Posterior mod air cell question, we could remember. SLN injury in a thyroid surgery patient, singing problem, otomycosis, wet news parents, collectively will be able to pass the paper. Fine. Thank you very much. Bye. Thank you very much. Thanks. Thank you. Thank you.